Good afternoon, ladies and gentlemen, and thank you for joining us this afternoon, either in person or online. I am Captain Jochen Richter, working for the alumni programs here at the Marshall Center, and it's my great pleasure to introduce our first alumni scholar since more than 1.5 years, Dr. John Quinn from the United States. John is one of 12 scholars of fiscal year 2020 that were not able to come to Garmisch due to the corona pandemic. Fortunately, we were able to invite him again, which now puts him into the unique position of being our one and only scholar in fiscal year 2021. In overall, he is the 82nd scholar since the start of our program back in 2005. John is currently serving in Prague as lead researcher at the Prague Center for Global Health, as well as a staff emergency medicine doctor in London. Most recently, he served as medical officer to the OSCE Special Monitoring Mission in Ukraine. Dr. Quinn has consulted to the WHO Mobile Field Hospital in northern Iraq, serving damage control resuscitation during Mosul operations. He holds a master's in public health, a PhD in hygiene and epidemiology, and is both licensed paramedic and emergency medical doctor with over 20 years of experience globally. Dr. Quinn has performed emergency medical assessments in Ukraine, Israel and Palestine, Iraq, Kurdistan, and Timor-Leste. He has established and operated remote medicine clinics in conflict zones and for remote communities, and has consulted for NATO and NATO partner nations in the health and medical stability operations sectors. He serves as an active participant in the NATO Military Medical Center of Excellence, Concept Development and Experimentation Cell. Dr. Quinn has worked in Ukraine, providing emergency medical consulting and training in tactical combat casualty care, prolonged field care, and forward resuscitative care. During the COVID-19 pandemic, he spent clinical time in the UK and for the OSCE. John is a 2019 graduate of the ESS East. As always, we would like to thank Dean Michter, Dr. Roloff, Colonel Kunze, Colonel Neumeier, and the college for their ongoing support of our Alumni Scholars Program, the faculty review community for their work in selecting our scholars, and a special thanks to Dr. Susan Loftus for her academic guidance for this research. She is going to moderate the Q&A after the presentation. Dr. Quinn has spent the last 5 weeks here at the Marshall Center focused on his research project, which is entitled Global Health Engagement in War, Data-Driven Decisions and Evidence-Based Policy. John, we look forward to hearing from you, and the floor is yours.
Thank you very much, Captain Richter, Dr. Roloff, Professor Loftus, the Alumni Association team, other faculty, and fellow colleagues. Thank you very much for the introduction, and for the next 30 minutes or so, I'd like to walk through some of the outcome and some of the details of the research for the last 5 weeks in this established Alumni Scholarship. Full disclaimer and declaration, all of the conclusions expressed here and detailed are entirely that of my own. They do not represent the Marshall Center or any official U.S. government policy, past or present. There are no additional financial or professional or ethical disclosures at this time to report, and the conclusions in this report are entirely that of John Quinn, myself. The presentation is intended for educational and presentational issues only. This does not represent or replace independent professional judgment. So really, the objectives are just to walk through and unpack the methodology, a lot of the terminology that are used throughout the concepts of global health engagement, but most importantly, for the next 30 minutes, I really want to be able to link patient care and the patient care paradigm within the emergency and pre-hospital medicine with that of the disaster response cycle and how that feeds into the current Department of Defense global health engagement cycle, and how they overlay and interlay with one another, and most importantly, how that helps and support the NATO alliance with DoD and with integration of partners. I'll also be walking through a little bit of the methodology and really presenting as the big results here of Georgia and Ukraine. One, Georgia, utilizing as a case study, utilizing the entire global health engagement cycle, and then that of Ukraine, which has a bit more mixed results. It's really on an evolving global health engagement cycle. And then provide a little bit of alternate analysis where global health engagement may actually fall short, sort of identifying some potential gaps, and then concluding with some outputs and some recommendations. So the research questions, the most important thing, this is what guided my 5 weeks here. This was what was accepted, and it really, does the Department of Defense get bang for buck for global health engagement? Is money spent, money well spent? And does global health engagement align NATO medical standards? It's a very clinical question orientated, as well as does it support NATO participation and membership for those partner states? And how does global health engagement promote U.S. foreign policy interests at all? As well as does global health engagement activities provide deterrence with a very well established understanding of NATO definition of deterrence, and does it serve broader NATO priorities in general as well? The additional clinical question is really within the Department of Defense in the paradigm of our clinical practice guidelines, which are published and rejuvenated on a continual basis. Do Russian hybrid warfare, do those Russian hybrid tactics actually require a change in thinking and a change in approach? And can global health engagement be the answer to those questions on a clinical basis? So methodology, very simply, qualitatively, conference calls, VTCs, reaching out to significant stakeholders and getting very important isolated data points, as well as long drawn out stakeholder interviews. Additionally, in November, there'll be a participation by myself in a military medical meeting to gain more data for the final report. Quantitatively, looking at foreign assistance donor tracking, this will not be presented today. However, in the final paper, looking at both military and economic investment over the last 2 decades by U.S. Department of Defense and other U.S. governmental agencies, and being able to really parse through where money is being spent within global health engagement activities, and understanding the trend and evolution of that spending as it relates to global health engagement, that is money spent and money well spent, or money earned. In the paradigm of this research. Also, very descriptively, looking at NATO percent of GDP in defense spending against member states and partner states, and really being able to understand where certain partners fit within the last 7 or 8 years as it relates to spending and global health engagement activities, and really looking at the NATO timeline. So looking at the past 2 decades of the evolution, the enlargement of NATO, as well as some significant security events that took place during that time, and how that may have impacted the evolution of global health engagement as it relates to specific Department of Defense policy and directives. And also looking at the membership action plan process for some specific partners, and kind of understanding the 3 most recent states, and 2 that we look at as case studies, figuring out how do they fit into a pre-map process, and does that help with global health engagement? Does global health engagement actually feed into NATO membership? So lexicon mapping, basic definitions so that we're all on the same page. Health security is something that has been used quite a bit in the last 15 years. There are many books written about it. It takes, sometimes multiple chapters to really parse through some academics' view of health security. However, the Department of State had a very simple understanding of health security and the definition thereof in some working groups in the late 1990s, with the product in the early 2000s of the Global Health Security Alliance and the Global Health Security Directive, looking at infectious disease across borders. So state, morbidity, mortality of infectious disease, and how it relates to crossing borders. It's a very primitive, very conservative view of the definition of health security. A much broader view, a much broader definition involves the World Health Organization looking at access to healthcare, access to primary prevention, secondary prevention, and tertiary prevention, and looking at more than just infectious disease across borders, but a much broader understanding about health and health security throughout not only regions, but globally. Most poignantly, in the current pandemic with COVID-19, global health security has a significantly expanded function. Global health engagement, said very simply, and there'll be a slide kind of detailing this as it relates to the Center for Global Health Engagement. Global health engagement is USG, U.S. governmental agencies and institutions engaging with partners within the health and medical paradigm. Interoperability has a micro and a macro definition. So interoperability at a very micro point is we have a piece of medical equipment. We want to be able to use that with a partner. The partner can be trained on it. They can use it in an isolated fashion. And in turn, they can give us their medical equipment. We can be trained on it. We can use it. It is very transactional in nature. The macro component is significant, and this definition is very difficult to obtain. However, the macro interoperability within medicine is saying, I can send you patients from my institution, from my unit, from any large organization to yours, a partner, and you will receive, those patients will receive the exact same level and quality of care across a standard medical paradigm that I would be able to provide for them, and vice versa in return. So this is a very high bar. It's a very high standard of interoperability. Interoperability is a word that is kind of used a bit more as a buzzword, but within medicine, within global health engagement, it is very specific to understand what you can actually offer and provide. Whether a patient is receiving Role 1 capability, medical point of injury care, and at one partner state, and going to Role 2 to an entirely different partner state, and understanding that they're receiving a higher echelon of care, yet they're receiving the same exact clinical paradigm. Very difficult to obtain. Medical readiness has a micro and macro component as well. Very simply, is an individual fit to deploy? Are they fit for mission at a very micro level? Are they medically fit and ready? At a macro level, medical readiness is looking at an organization, a unit, a specific medical capability to provide absolute clinical best practices based on the data and information available. That's very difficult to maintain medical readiness, especially during times of significant peace when it relates to other warfighting activity and requirement of that data. Standardization is exactly that. You can see the document screenshots on the right, not only from Department of Defense, instructions as well as Department of Defense directives, but also that from NATO STANAG. So it's just standard agreements, putting through exactly what the definitions are. Standardization within healthcare is looking at quality. So what you are actually providing may be slightly different, but the outcome has to be the same. That is the standard. You have to have that standard outcome. Deterrence and resilience are significant within NATO. They're very expanded definitions. Deterrence is not only protecting from attack, preventing attack, it's also freedom of action, freedom of decision. It relates to individual liberty and freedom, as well as rule of law. And it's very specific, but it feeds into resilience. So within a community, within a military, within a partner state, resilience is also the ability to brace for, to prepare for, and to receive the impact of a significant insult. That insult is a risk, a threat, a hazard, and being able to not completely collapse in a state of fragility from that, but be able to absorb that, be prepared for it, be able to respond to it, and maintain basic services within that process. That's within an organization and within a partner state. Lethality is the ability to cause death. This is very important as it looks to when you're looking at security cooperation for lethal aid versus non-lethal aid within global health engagement. This is very specific. Morbidity is a rate. You're looking at a rate of disease. What is the morbidity of a given disease? Communicable versus non-communicable disease. Infectious, non-infectious. That is looking at the rate and how that affects a population. These numbers are very helpful when you're looking at any sort of battlefield data as it relates to morbidity. What is actually taking place and how unwell are patients. And mortality is the ability to cause death. So now that we all have a decent understanding, a baseline understanding of some of this lexicon mapping, what does global health engagement mean? What is it really defined as it relates to Department of Defense, Center for Global Health Engagement? As mentioned previously, it's all USG interaction with partner states. It has to be a coordinated effort. It has to build trust and confidence, and we'll see that within the global health engagement cycle. It requires the use of tools. Global health engagement itself are tools. And the tools in the toolbox we'll be seeing kind of throughout this presentation. But most importantly, global health engagement activities must establish or reconstitute, maintain, or improve the capabilities of the partner nation, the partner state, the partner military, the partner disaster response, as well the Department of Defense. This is not a one-way street, this is a two-way street. This is the most significant definition of global health engagement. This slide is adapted from the Center for Global Health Engagement with permission. So what is John Quinn talking about, and why are we talking about patient care and global health engagement activities, and how on earth does it relate to NATO interoperability? Well, at the very top of this is a very simple emergency medical services cycle. This is what happens when a patient is injured on the street. This is the basic concept of pre-hospital emergency medicine. We have to have multiple functions in place. There's many parallel systems to what you see on the screen here. We get hit by a car, we have to be able to call 999, 911, 113, 112, etc. We have to be able to have a response, get the patient to the right hospital, get the right doctor to see the patient, refer the patient, get adequate level of care at the trauma center, at a cardiac center, at a stroke center, get the patient admitted to ICU, get them discharged from ICU, and all the time, we also have to be able to maintain that standardization, that quality improvement, so that we are prepared to receive another patient. You're looking at a microcosm of patient care, which is the exact same as a disaster cycle. And this disaster cycle feeds into the global health engagement cycle. They are overlays one on top of the other, and they have the same function, they just have much, much broader scope. So disaster strikes, instead of that patient at the very top where you saw the incident, it's a little bit on the left, but it's the same concept. Disaster strikes a community, it strikes a partner. You have individual disaster response. These are immediate events that take place. There is a response and relief. These are the machinations that have to go into play. You have to have these within an institution to have some level of resilience to be able to respond, and then you have to be able to maintain basic restoration of basic services. This is not back to baseline. This is basic restoration of services, and then reconstruction, which can take many years, fulfilling the full resumption of services, plus preventative measures, which is very difficult, especially as it relates to global health engagement, as we'll see. And there's also mitigation of risk assessment prevention, which is hazard mapping, really preparing for the next disaster, looking at vulnerability assessments, figuring out what went wrong. This is the lessons learned, this is the lessons shared phase. And then preparedness, contingency planning, warning and evacuation, consolidated preparations, getting ready for that next disaster. This is the global health engagement cycle. What you just saw, the patient care, the disaster cycle, the global health engagement cycle. How do you enter the global health engagement cycle? Well, you don't have a patient being hit requiring an ambulance necessarily. You don't have a disaster striking a small community or a partner state. However, you have one of these major sections: cooperative threat reduction, stabilization requirements, humanitarian and civic assistance, forced health protection, foreign disaster relief in general, irregular warfare requirements, all put forward as Department of Defense directives and initiatives, feeding into senior leadership requirements and strategic objectives. Well, what is the output of that global health engagement cycle as you identify one of these points or all of these points to engage? Well, it's maintaining influence, achieving interoperability as described and defined previously, coordinating mutual activities, the sharing of information, lessons learned and lessons shared, building trust and confidence for strategic objectives of enhancing the readiness, as described previously at the micro and macro level, promoting stability and security, improving confidence with that partner nation within their governance that leads to deterrence, improving interoperability in general, improving DoD medical force readiness. So DoD Med is receiving readiness by that engagement activity, even if they're not actively engaged in warfighting. Strengthening partner nations' MIL-CIV and health sector capacity. Health sector in general and health security, providing that it within the civilian sector improves the defense force structure, and vice versa, improving defense force structure helps improve health security in general. This is done, if you look on the bottom, you can see MIL to MIL, so this is M2M, this is also military to civilian, M2C, as well as military to multilateral stakeholders. So the way that this is carried out is multifactorial. Okay, so plain and simply, based on this research, we have tools in the toolbox. We can see a wrench and a pocket knife. We have training that leads to both capacity, capability training, competencies being increased for Department of Defense, as well as for partner nation. We also have interoperability training. These are all global health engagement tools. These are tools used for specific ends. And we understand that the capacity and capabilities and competencies of the Department of Defense are gained. This is not only the research output from this specific research project, this is also the output within the literature of the last 5 years or so. Overwhelmingly, the Department of Defense receives significant capacity, capability, and competency sustainment due to global health engagement activities, a very key point. However, as it relates to partner nations, when we spend money and we engage with global health engagement activities, whether it's with basic training, as you've seen the same picture from before, and money and other additional training and material support, is that just a tick in the box? Do we just say, okay, great, we're done, and we'll just leave it there? Or are we going to have to conduct more monitoring and evaluation and be able to understand, does NATO benefit from this? Do partner nations get into NATO membership or escalate their partnership status because of this engagement activity? Or is it just DoD wins and partner nation hopefully wins? Well, before we really answer that question, if we look at the entire timeline of NATO for the last 20 years or so, there's been a significant enhancement and enlargement across multiple countries and multiple regions. We've seen significant growth also with unfortunate security events, Article 5 in Afghanistan. Additionally, in 2008, we had a significant invasion with Georgia. It's a very complex security case. However, there was kinetic activity that took place, as well as the NATO Bucharest Summit, which really set out that membership action plan, not only for Bosnia-Herzegovina, but also put some language down as it relates to Ukraine and Georgia. So there's a significant flow and growth of NATO participation and enlargement. Additionally, in 2013 and 2014, there was an escalation of kinetic activity starting on the streets as social unrest and leading to Russian annexation of Crimea and invasion of Donbass. The entire time, throughout the conflicts that have been seen by Department of Defense, most notably in Afghanistan and Iraq, however, there are other smaller conflicts that took place, there were global health engagement, Department of Defense initiatives and directives that escalated and evolved over this exact same timeline as well. Increasing the terminology, increasing the spans and the vision of global health engagement, and what was actually supposed to be established from global health engagement. What are the objectives, both the tactical and strategic? And there was also in 2016 the establishment of the Center for Global Health Engagement, which really works as a central repository for all global health engagement activities, as well as for monitoring and evaluation to understand, is it still helping, or what else needs to be done in the future, and how is Department of Defense benefiting materially from that. Now, this is the evolution of the NATO sort of timeline. We can see it jagged through, but what about the money spent and the partner nations' money spent? Defense expenditures as a share of GDP are a common metric, and we can see here, this is data from this summer, and this is the NATO guideline. This is standard 2%. These are all NATO member states. But is NATO and Department of Defense, are they really funding this global health engagement activities? However, partner states, are they not really contributing? If they are contributing, are they on parity with additional states? Or what is really being received as it relates to money spent? Well, if we look at, again, this is year on year, so 2014 is the column on the left, 2020 is the column on the right for Ukraine. We can see it on relative parity with the United States, not for 2014, however, you can see the escalation, country actively engaged in kinetic warfare. We can see here with Georgia, just above that NATO guideline and above that threshold in 2014, and then slightly dipping below the threshold as it relates to 2020 data. Additionally, Bosnia-Herzegovina, much further on the right of this data between Belgium and Luxembourg. If you can see here the sort of trend value going down. Additionally, two aspirant nations, most recently North Macedonia and Montenegro, 2017, and you can see really where they fall within that paradigm of money spent as GDP per capita. So where DoD decides to invest, where NATO decides to invest in global health engaged activities, as the country is getting towards that NATO guideline of 2% and above, is that money well spent, because you're being able to put two different baskets of money focused on the same exact outcome. And does global health engagement activity really play a role with that? Well, we can look at one case example, and again, just to bring everyone back into the room, disaster management cycle, it is overlaid. So we're walking through that whole cycle again, but we're doing this with Georgia. And we're walking through over the timeline, the same exact highlighted sections. NATO partner Georgia labeled interoperable with NATO troops. Deployed to Afghanistan between 2009, 2010 was the process that began. It was 2009, 2010, and 2011 deployment. Georgian troops fighting along NATO troops, completely interoperable. However, they're also receiving same level of casualties. They receive the best medical evacuation and point of injury care available in the world. So they're receiving this excellent point of injury care, role 1, role 2, role 3, and in some instances, a lot of these Georgian partner troops are going back to areas, NATO nations within Europe, as well as in North America, receiving excellent rehabilitation surgery and rehabilitation care. Other NATO partner troops of Georgia are actually not going back to these NATO members. They're not getting medically evacuated. They're actually going back to their country of origin, and they're receiving a slightly substandard level of care. However, that impacts the health security, that impacts the civilian and military healthcare infrastructure, because there's a loss of confidence within that team. Some of these patients are receiving this very high level of care, and they're coming back with amputee prosthetics. Others are not receiving this high level of care. A gap has been identified. European Command identified this gap and said, listen to senior leadership, we may be able to fill this gap, increase amputation wounded warrior program. We'll be able to provide additional material support to provide interoperability. These troops are fighting as interoperable alongside NATO troops, and we may be able to establish that capacity, those competencies, and those capabilities for a partner nation. So the program initiated, and it was being able to provide significant, not only for the partner nation, significant capacity and capability and competencies, also for the Department of Defense. How? Why? Well, the rehabilitation program is only as good as the number of patients that you're feeding into the system, as well as being able to build up rehabilitation amputee process and programming through physical rehabilitation and physical therapy. You have to be able to have multiple patients. You have to be able to see patients across multiple years, 5, 6, 7 years, in some instances longer. So the Department of Defense is receiving patient information, it's receiving wounding information, and it's being able to provide best practice of care. So in 2021, this culminated with the Department of Defense supported and NATO supported Maro Makashvili Wounded Warrior Rehabilitation Center, providing Georgian soldiers with critical physical and occupational therapy, as well as being able to serve as a center and a center point for global health engagement activities within Georgia. So the kind of conclusions there with this disaster cycle is physical rehabilitation sustainment programming for competencies, capabilities, and capacities. So DoD and NATO partner, and as well as Georgia, NATO partner, are both receiving the benefits of this program and this project. This is a full and complete cycle of the global health engagement cycle with one program as it relates to a NATO partner nation, which fought along troops as interoperable, NATO troops as interoperable. When it comes to the case study for Ukraine, the results are still slightly mixed. It is an evolving global health engagement cycle. It is an evolving crisis. As we described previously, there were significant weapon systems being used in 2014, and as Russia annexed Ukraine and took over much of eastern Donbass, eastern Ukraine. The political pressure was significant to deconflict with Russia, to provide non-lethal security and military support, really focusing on the health and the medical component. It was a great opportunity not only for global health engagement activities, but also in the humanitarian sector. There were a scatter of, from 2014 to 2016, multiple programs offered not only by European Command, but additional USG activities. There's related everything from Humvee ambulances being provided, basic point of injury care to provide tactical combat casualty care training, which is very affordable to be able to provide this level of training, as well as Role 1 and Role 2 capability being provided, and this portfolio grows rapidly. So what we see by 2015, 2016, Defense Forces of Ukraine have a decent Role 1 and Role 2 operation. In some instances, the Role 2 supersedes that of other partner nations and potentially of some member nations, purely because of the cadence of warfare that they have experienced. And they're really seeing an increase and a ramp up. Point of injury care gets better. We'll see some data in a moment, and capability increases significantly. So we have that tick in the box. That technical approach, capacity, capability, competency is achieved. We tick the box. However, the evolution of warfare did not stay the same, and it grew significantly. Wounding patterns changed. Weapon systems that were used changed. Significant changes to weapon systems and capabilities changed. And it became very difficult to get lessons learned and lessons shared out of defense forces, being able to understand how Department of Defense and other NATO nations can benefit from that information. It also became almost unmanageable, the level of programs and the difficulty in the number of programs. Evaluation and monitoring was a challenge. Not impossible, but a challenge. So what we had really was, is the capacity and capability and competency being established? Is it being maintained? And if so, on what metric? And if so, where? Well, one silver lining is that we actually did see the NATO-Ukraine Commission evolved out of a Department of Defense initiative in support of the Defense Strategic Bulletin. And this document evolved from a very few number of pages to a very expansive, very detailed, NATO-oriented document focused on not only security cooperation, but also global health engagement activities on a line-by-line bullet point. Now, this document is not a membership action plan for security cooperation with NATO. It is an action plan. However, in the event that there is a political window, this will likely become, elements of this document will likely become a membership action plan for Ukraine. The Global Health Engagement Portfolio Assessment is still ongoing. It culminated in the 2021 Ukraine Security Assistance Initiative, which is a mass amount of significant security cooperation initiatives to include a lot of medical evacuation chain support. Again, back to that point of injury care, Role 1 and Role 2. However, with partner nation Ukraine, challenges do persist. Lateralizing decision-making is an issue for mid-level professionals within the defense forces. Lessons learned and lessons shared are limited. There are significant lessons to be learned from Ukraine. However, that sharing, that lessons shared, that information exchange is limited, and it needs to grow, it needs to evolve. Global health engagement will be able to provide that. Of course, the weapon systems and the escalation with hybrid warfare is a significant challenge to damage control resuscitation and damage control surgery, and that exchange and interoperability. So those are some of the challenges. However, there are some benefits. For example, NATO was able to offer, NATO specifically, so NATO member states were offering Ukraine, as it received its fourth spike just recently in summer, significant COVID-19 relief, significant medical cooperation and medical material support from a multitude of NSPA and other medical support agencies being able to provide aircraft from throughout Europe and elsewhere into Ukraine with basic medical material support. These same aircraft, these same flight lines can be used for additional lethal weapon system support as well from the NATO support structures. So current outcomes, point of injury survivability increased to 95% in 2018 and 2019. These are official data from ODC as well as from Ukraine Defense Forces. This is not, I'm not telling you right now the cause for this increase. Some units in 2015 saw 50%, but this is likely directly related to point of injury care, so that tactical combat casualty care, training, access to all of the material that's required for tactical combat casualty care, as well as access to Role 1 and Role 2. Specifically within that Role 2, the damage control resuscitation and damage control surgery. How the Ukrainian partner state did this, we have not yet described. And global health engagement will help us describe exactly how this worked and if it is transferable to clinical practice guidelines within Department of Defense. Will Department of Defense be able to have significant benefit from this information as we unpack how this actually took place? Additional outcomes, the National Association of Emergency Medical Technicians provides trainers. There were 4 trainers in 2016. There's over 35 licensed NAEMT trainers right now in Ukraine being able to train the trainer. A significant option for standardization and NATO interoperability as it relates to the National Association standards. There's an EMT basic course overtaken by NATO partner states, mostly trained in the West, although there are training sites in the East as well. As it relates to the amputee program, so this is not Georgia, we're in Ukraine. The amputee program and rehabilitation program took 20% of amputee patients to return to active duty. In 2014, that number was 0. That is directly related to the physical rehabilitation, surgical rehabilitation program offered by Department of Defense over a 4.5-year period. It's ongoing, but these are some data that are very, very helpful. There's also the Ukraine Defense Forces Medical Command have a Role 1 evaluation received certification from the Military Medical Center of Excellence for NATO. So there was an official evaluation, a significant feather in the cap for Ukraine partner state. So this is just sort of the good, the bad, and the ugly of that cycle. This cycle is going to continue to turn. This cycle requires additional input and additional monitoring and evaluation. So basic results, global health engagement and NATO partner interoperability are indeed correlated. However, there is no definitive causation to membership. Back to the research questions, does DoD get value for money? Yes. DoD and NATO across the alliance get value for money through some of the projects and programming discussed, and also what I'll be able to discuss during the question and answer session. Does global health engagement align NATO medical standards? Yes, but there's a rate limiting step. Lessons learned and lessons shared. We can obviously, NATO can share clinical practice guidelines, Department of Defense can share clinical practice guidelines, but those are not rigid. They're medicine, it's clinical medicine. It requires input. That input requires data. That data requires partner nations to provide what their data is. Does it support NATO participation and membership for partner states? No, it does not. Global health engagement does not offer that. These are political decisions that are required. However, the pre-map process described in Ukraine, to a lesser extent in Bosnia and Herzegovina, to a much lesser extent in Georgia, also provide not a technical and tick box approach. However, they provide the ability to increase both the civilian and military medical capabilities by ascribing to the NATO military medical standards and trying to fulfill that standardization and that quality alignment in healthcare. That is a multi-decade process. That is not something that can be ticked in a box over the course of 12 to 18 months. It's a significant process, significant political and economic buy-in required to do that. How does global health engagement promote U.S. foreign policy interests? Global health engagement is a tool. It's a simple modality. It's not an outcome alone. It requires strategic prioritization. So if you think back to that cycle that you saw, it required European Command to identify a gap. It required significant senior leadership to do some heavy lifting and say, this is actually strategic prioritization. We need to put this into our priorities and push the program forward and use that global health engagement as a tool to achieve those U.S. foreign policy interests. Do global health engagement activities provide deterrence and serve NATO priorities? That is a huge question. You can see here, I won't read for you, the clear definition of deterrence by NATO. And it is an expanded definition. It is not something as simple as show of force. It is not something as simple as prevent. It is not simple as respond. It is actually expansive. And if you look at the last entry there, really looking at values that stand for individual liberty, democracy, human rights, and rule of law. Go back to the health security definition. If you increase civilian health security and military health security mechanisms, you're increasing that entire health security across that community, which you're providing some elements of this. So the answer is partially. The clinical question described, which is quite a challenge indeed, within the DoD CPGs, do Russian hybrid warfare and hybrid warfare tactics require a change in thinking and approach? This requires more lessons learned and lessons shared data. If you look at some of the symbols on your left, this is the tactical combat casualty care paradigm. You have prolonged field care. It doesn't show up as well. There's also emergency war surgery course focused on damage control, resuscitation. There is a Thor initiative put forward, really pushing early resuscitation, early access to blood based on data and based on evidence. There's combat surgical care, en route combat casualty surgical care, and en route combat care. These have clinical practice guidelines, clear, based in evidence, clinical practice guidelines, but they require data. And that data is continuous. Who deals with the data? Well, the data is dealt with by military medical centers of excellence for NATO, Civ-Mil interoperability to a much lesser extent, the NATO Military Medical Center of Excellence, and within the Department of Defense, multiple structures, most notably the Joint Trauma Registry. The Joint Trauma Registry is able to feed back into everything that you see on the left, as well as many other pre-hospital paradigm clinical practice guidelines based on evidence that it captures globally and also from the lessons from Iraq and Afghanistan. However, the weapon systems used in Iraq and Afghanistan are much different than what are used in Ukraine and other hybrid warfare environments. The Buk, the Grad rocket being used in an entirely different domain, thermobarics, the threat of CBRN, the threat of little green men, and of course cyber. Well, Ukraine partner nation and other partner nations have been dealing with this on the front line. So how do we get that data into the concept of the data for clinical practice guidelines? There needs to be lessons learned and lessons shared. That is the rate limiting step, and global health engagement is able to provide that on a continual basis. So before I kind of wrap it up a bit here, a bit of an alternate analysis snapshot. This is the sort of red team. This is how can global health engagement actually not help? How can it do harm? How could this concept, this modality, this tool actually disrupt in a negative way? Well, it can fracture NATO. If NATO member states have divergent interests and significant interest to conduct global health engagement activities increase for one state and another, this can actually have divergent strategic initiatives that can actually fracture NATO. Strategically, security cooperation normally takes place in Ukraine, as one case example, in the far west. It is to be non-provocative. There is a lot of security cooperation. However, when it comes to medical support, that is very proximal. That is proximal to the line of contact, that is proximal to the Joint Forces operation, that is much further east. And so you can imagine with a non-lethal military medical support, if there was any type of security event that would take place, it would be a potential to involve a NATO partner conducting global health engagement activities, and it would actually be a potential for a significant security event if something were to occur. So there is a significant strategic gap there that has to be closed. Also within the enhanced forward presence, global health engagement activities take place quite a bit in Latvia, Lithuania, Estonia, and to a lesser extent Poland. And again, if there was a security event that took place within the enhanced forward presence during global health engagement activities near the border or near other standing troops, it would be a significant loss of the initiative. On an operational and tactical level, this is something that really can't be glossed over. Medical innovation, emerging technology are what drive evidence-based medicine. And so when we share this medical information, innovation, and technology with partners, and they were to build upon it, but not in return share it with us, we would actually lose some of that innovation and technology. So that what is required is that continual partnership, that continual sharing, and that engagement over a sustained period of time to be able to benefit from any additional advancements that are made upon that. And to a much more significant event as relates to infectious disease, medical intelligence losses. What does that really mean? Well, the sharing of information is very important across borders. We've just seen all of this with COVID-19. This is a challenge indeed. However, we need to prepare for the next. And the next is going to be based on data. All of the policy that is made, all of the reactions and response that are made must be made on data. If we are not sharing that medical intelligence data at an early point through biosurveillance, cyber surveillance, biosurveillance, we will not be able to maximize those results. And we'll have a loss of adaptation to some of the new threats, both within the infectious, non-infectious disease, as well as with other land, sea, airspace, cyber threats. So basically, in closing, some policy recommendations based on the available evidence. Invest in global health engagement. DoD and NATO readiness and interoperability and resilience improve because of it. Invest in this. It is a very low cost, significant output. Increase in global health engagement activities across all domains and sectors. This is a very cheap investment with high yield return. Increase in senior leadership involvement. It is very important to have senior leadership involvement to make sure these tools really meet that strategic objectives. Increase global health engagement research, information exchange, and lessons learned. A lot of the examples were used were really focused on Ukraine and Georgia. However, this involves all partner nations, both within the region and out, and really have them feed information into the NATO Centers of Excellence, not just Military Medicine Center of Excellence, but others as well. And for think tanks and academic institutes, such as the Marshall Center, to really consider establishing a point of contact, a chair, a desk, an institute in and of itself focused on health security and global health engagement research activities and initiatives. This is the absolute marquee center for U.S. government policy consideration within the region. And being able to focus on health security threats and global health engagement activities really needs to be a focus to be shared. That information needs to be researched as per best practices as well as shared across all USG. So basic outputs before I close for questions. There will be a short review paper that will be published based on really this presentation, on the output of the results. There will also be a peer review publication, which will be really looking at a lot more of the detailed data capture that is still ongoing. There is a comprehensive report that will be given to European Command, answering some very specific questions, as well as being able to provide an additional briefing for them in the first quarter of 2022. I will be taking part in a military medicine subcommittee, which will be collecting some data points from the Defense Forces of Ukraine for that comprehensive report, as well as potentially for that peer review publication. And I also hope and look to encourage the broader alumni promotion and participation activities going forward. I think this is an absolute excellent center for research, and being able to conduct best practice research with colleagues and faculty, it is an absolute privilege and an honor to be able to do that. So I thank you. And with that, I'll be able to take questions from online and in the audience. Thank you.